Good morning, everyone. Welcome. Happy Friday. So happy to see everybody joining today. And I'm Eleanor College. I'm a family physician. I work in East Toronto, and I'm also the CPD program director for the Department of Family and Community Medicine. I'm really delighted that we continue to be able to collaborate with the OCFP to bring you these sessions, and really looking forward to today's session where we're going to be providing some infectious disease updates on COVID and syphilis, as well as discuss the Osteoporosis Canada guidelines. And I'd like to turn things over now to our OCFP president, Dr. Mihaly Kuminen, to open the session.
Thank you, and good morning, everyone. Welcome. Thanks so much for joining us. We do have a great session lined up, and I'd like to take a moment to thank our speakers for being with us today, and a reminder to all of you that this is a MainPro accredited session. Okay, next slide. So just moving on to our land acknowledgement. We acknowledge that the lands on which we are hosting this meeting include the traditional territories of many nations. The OCFP and DFCM recognize that the many injustices experienced by the Indigenous peoples of what we now call Canada continue to affect their health and well-being. The OCFP and DFCM respect that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. I invite us all to reflect on the territories we are calling in from as we commit to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. And I'm calling in from Kitchener, the lands traditionally used by the Haudenosaunee, the Anishinaabe, and the Chinantan peoples.
Back one slide, please. Thank you. So this photo, which was taken actually when photos were still taken on camera, so quite a few years ago now, is a beautiful stand of birch trees in a community north of Sioux Lookout called Neskantaga, a community that I had the pleasure of working at in the early 2000s. And I thought that, in honor of the changing seasons, the fact that we're into April, which also contains Earth Day, and the importance of planetary health and the health of our patients, that I would reflect today on the role of Indigenous peoples and the environment. And you may know that Neskantaga, along with many other communities in that area, sits within the Ring of Fire, which is I'm sure many of you know, is a resource-rich area in the James Bay lowlands, and has become a hotbed of interest recently because some of the minerals it contains are used in things such as batteries that we use for electric vehicles. And in fact, the Chiefs of Ontario had recently asked for a moratorium on online mining claims in the area because some of the communities are overwhelmed by the number that they're receiving. This moratorium wasn't successful, and I'm not going to speak to the politics of that or pretend to be any form of expert on the issue. But it did cause me to reflect on how often it is that it's the Indigenous peoples and communities in Canada that stand up and ask our government tough questions about how we should develop resources. And I know many Indigenous people have a very different relationship with the earth and the environment than many of us, including myself, were brought up with. And I often reflect on how the knowledge that comes with that relationship is so important as we move forward and try to sustainably develop our resources and protect our ecosystem and ensure that we combat climate change. Next slide, please. So just a reminder that this session today is part of a series. All of them are available online. Please check them out. You can either listen to them or watch the videos, and today's session, as well as the resources that we recommend, will be also posted later. Next slide, please. So at this moment, we'll move on to introduce our speakers, and I'll just do the next slide too, because we have a few. And next slide. So I'll now turn things over to Dr. Evans to introduce himself and speak to his disclosures.
Hi there. Good morning. Gerald Evans. I'm an infectious disease physician at Queen's University and Kingston Health Sciences Centre in Kingston. I have served previously on the Ontario COVID-19 Science Advisory Table. And I certainly, at present at least, also chair the Infectious Disease Advisory Committee for Ontario Health. The only other conflict I have would be related to some talks that I did in Australia last year, attending the Australian annual infectious diseases vaccination conference, where I discussed COVID vaccines. happy to be here this morning.
Thanks so much, and lovely to have you back, Gerald. So now to Dr. Sid Feldman.
Good morning, everybody. Yeah, I've had some research support from CIHR, from the Canadian Foundation for Healthcare Improvement, and from the U of T Academic Health Science Innovation Funds. I've received stipends from the Ontario College of Family Physicians and from the Ontario Osteoporosis Strategy. I'm a voluntary member of Osteoporosis Canada for many, many years on their Scientific Advisory Council. And I get salary support from U of T for my role of being head of the Division of Care of the Elderly, and from Baycrest for the role of chief, and then some consulting fees for our international unit, the Baycrest Global Solutions.
Thanks so much, Dr. Feldman. Happy to have you here too. And just turn things over now to Dr. Dan Wachowski.
Yep. Hi, good morning, everybody. Daniel Wachowski. I'm a public health and sports medicine physician, but the sports medicine never comes up on these calls. Maybe one day it will. But I'm also one of the Associate Chief Medical Officers of Health for the ministry, and I have to declare.
Thanks. I would just note Dan's with us till about 8:30. So if you have any questions for him, then post them in the Q&A. Dr. Mahele Kumanen.
Hi again. My name is Mehle. I'm a family doc in Cambridge, and I'm currently serving as the OCFP president and the deputy chief of family medicine at the Cambridge Memorial Hospital. And neither of those roles pose a conflict for today.
Thanks so much, Mahele. And as I already introduced myself, I'm Eleanor College. I don't have any particular disclosures other than an honoraria, which I don't think poses a conflict of interest for today. Next slide, please. So just a reminder in terms of participation for anybody that's new to the session, please use the Q&A section to post your questions. If you see a question that you think is great, then please upvote it so I know to prioritize those ones when I ask them of the speaker. And then, of course, continue to use the chat to share resources, to network with others, and comment and enjoy the morning. Just make sure you put your questions in the Q&A. That would be terrific. Next slide, please. So for this morning, we're going to hear first from Dr. Evans regarding COVID update, as well as the return of syphilis, unfortunately. And then we'll break for some Q&A and then turn things over to Dr. Feldman to talk about osteoporosis. We plan to be done the main content before 9, but have things open until 9:15 if there's additional questions to be answered at that point. Next slide, please. And I'll turn things over now to Gerald. Thanks very much.
Thanks very much, Eleanor. I thought it was very appropriate, since I live in Kingston, where we are going to experience the totality of the solar eclipse on Monday, to remind people that this is the corona of the sun and this is a coronavirus, just because they kind of go together. And the spaghetti at the bottom there that you just saw briefly, I will talk about in a minute, although Eleanor's already mentioned that we're going to be discussing very quickly a little bit about what's happening with syphilis, particularly here in Ontario. So next slide, please. So where are we with COVID? This is a pretty impressive graph. This is laboratory confirmed weekly cases from the province. This updates today, so this is last week's. But what you can see is that we've had a very dramatic drop in COVID numbers, at least laboratory case numbers, confirmed case numbers through the month of January. Much of that is because we actually saw a rise in influenza. And for those of us who've been tracking COVID now for about 4 years, last year and this year, every time we've seen a surge in seasonal influenza, we've seen a drop in COVID. So this may be one of the reasons why we've seen this impressive drop. Next slide, please. The other thing we look at, of course, are outbreaks in congregate settings. This also includes hospitals, of course. And what you can see is another graph which demonstrates that exact thing that we just saw in the previous graph, which is a dramatic drop in the month of January through February into March. And if you take a nice horizontal line across the bottom of that graph, we're essentially down to the same number of cases and outbreaks that we were at in May and June, where we had an enormous lull in COVID-19. Next slide, please. The other thing that we can look at is test positivity across the province. And yes, in a way, the number of tests we've been doing has been steadily dropping, but it hasn't dropped so dramatically that this could be really an artifact of the fact we're not testing as much. And what you can see here, and I've given you two thresholds, red line is 20% test positivity, the green 10%. And these are sort of where we demarcate high versus moderate versus low. prevalence of the virus out in the community. And you can see now that since the early part of February, provincially, we've been very, very low, down towards around 5%. So again, another marker that tells us that the activity of COVID out in the community is actually quite small. Next slide, please. This is the wastewater signal for Ontario. And again, it's a kind of a repetitive theme here. This is not yesterday's graph, because I got these slides in before the new graph was posted in 4:30, but yesterday's wastewater signal Ontario was even lower with a more sustained drop. Next slide, please. So if we look at these markers, and these are really, I guess you could call them surrogate markers to some extent, outbreak numbers, test positivity, and wastewater detection, all of those are dramatically down. We are in a position, at the moment at least, that mirrors where we were in May and June of last year. And again, the reasons for this are obviously some degree of changes in seasonality. We're still seeing viral dynamics going on, and we've seen the impact now of the seasonal influenza wave, which is now beginning to die out. The other little one I'll throw in there is OC43, which is a human coronavirus, which we've had for a few hundred years circulating in the global population, also was at a peak this year, and that may have also made a contribution through viral interference in reducing these COVID numbers. But at the moment, things are looking good. Next slide, please. So what's contributing to this? One of them is this concept of hybrid immunity. We now know that virtually everyone has had COVID. Very small numbers of people have not, and they've probably been extremely careful and made sure for personal reasons that they've not had contact, but it's becoming increasingly rare to be someone who's never had COVID. And the combination of vaccination and having had a previous infection actually contribute to something we call hybrid immunity. And that immunity seems to be very impressive. And because coronavirus immunity tends to dip, and that we've known about for decades now, this constant boosting, either through vaccination and or infection, really allows for a durable, sustained response that's protecting the population. Next slide, please. So just very quickly, this is some data from the American Vision Network, which looked at immunocompromised individuals who received the XBB vaccine in the fall. And what I've circled in red there is the adjusted vaccine effectiveness. And you can see that there was a reduction of about a third in hospitalizations as a consequence. So vaccine continues to be effective at reducing some of the surrogate points, markers that we have for severe outcomes. And as you can see, it's pretty well sustained out through virtually about 3 to 6 months. Next slide, please. I'm putting this up very, very quickly because I think this is one that's really important. As many of you know, there has been a lot of misinformation and disinformation about the vaccine causing thromboembolic complications. This was actually a large study of 10 million vaccinated people versus 10 million people who were unvaccinated from the UK, Spain, and Estonia. And what you can see here in these colored graphs with the vertical line there representing 1 is a reduction actually in post-COVID cardiac and thromboembolic complications. So these vaccines actually protect you from some of the thromboembolic complications and cardiac complications like heart failure, stroke, myocarditis, pericarditis, as compared in people who have had COVID and have been hospitalized. So these vaccines continue to be very impressive in their effectiveness, both in preventing disease, certainly within the first few months, and as well reducing complications. Next slide, please. So this is the current recommendation that came out here in Ontario back last month, and talking about the use of the XBB vaccines. Again, a recommendation that in infants and young children, if they're at high risk of severe illness, they should receive the vaccine with an additional dose 8 weeks later if they're moderately to severely immunocompromised. If they're otherwise unvaccinated, they may receive the vaccine and they should complete at least a 2-shot series, but that's not absolute requirement if they're not at high risk. For everyone else over age 5, and that includes all of us adults, if you're unvaccinated, you should get at least 1 dose of the XBB vaccine because you've probably had COVID, and that's going to help contribute to hybrid immunity. If you're moderately to severely immunocompromised, an additional doses requirement is recommended. And NACI, the National Advisory Committee on Immunizations, published this winter a suggestion that in the spring of 2024, a number of populations should be advised to get an additional dose, and that includes adults over 65, those in long-term care and congregate living settings, settings if they're over 6 months of age and are moderate or severely compromised, and anyone over the age of 55 who identify as First Nations, Inuit, or Métis, and their non-Indigenous household members if they're 55 years of age and older, because we know that that population does have a higher risk in general for more severe outcomes. All other individuals, it is currently recommended, not currently recommended to necessarily get a spring dose, but that is individual, and you may make a personal decision to get that. Next slide, please. So let's very quickly talk about syphilis. And this is a title that all my infectious disease colleagues and I are using whenever we talk about syphilis. What's old is new again. And although these graphics don't come out very well, what we've seen is an increasing rise in two forms of syphilis: infectious syphilis, which is primary, secondary, and early latent, and congenital syphilis. And it's been consistent across the country. This basically is a little sort of picture of what's happening across Canada. Next slide, please. Here in Ontario, we've identified the same. This is the most recent numbers that I've seen published. And so we're a couple of years out of date. This is very typical of Canada. We're not very good at real time getting the information out. But you can see that there are a number of areas where syphilis rates per 100,000 population are relatively high. They include the northwest part of the province as well as the GTHA, or the GTA, essentially. And where I live here in Kingston, Frontenac, Lennox, unfortunately, we are also a little bit on the high side. Next slide, please. So this is some more recent numbers up to 2022. And what you can see on the left-hand graph is the rise in infectious syphilis cases. So this is primarily primary and secondary syphilis. And on the right slide, you can see the rise, unfortunately, in early congenital syphilis. So this is the real challenge that we have right now. With syphilis rising, there are going to be more cases of pregnant women having syphilis. And unless they're screened, and screening is very simple and straightforward for syphilis, it's one of the most cost-effective serological tests we have, then we're going to see congenital syphilis cases beginning to arise. And we always want to treat pregnant women who have syphilis while pregnant, because that protects them, of course, and their unborn child. Next slide, please. So this is just a very quick algorithmic structure of the syphilis testing in Ontario. A lot of people get kind of freaked out because the first thing they see is this CMIA assay, which is a chemoluminescent microparticle immunoassay. It's just looking for antibodies against syphilis, and so it's very sensitive. And if it's positive, we then go to the traditional RPR, rapid plasmid reagent test. Please, everybody, remember RPR and VDRL are the same tests. RPR is done on a card, VDRL is done with a microscope. So an RPR is really much easier to do, and that's what the lab does. They will report out a titer then, and of course, they'll then undergo specific syphilis confirmatory testing with the treponema pallidum absorption test. So the RPR is probably the critical test that you're looking at there, because that titer tells you a lot. Next slide, please. So what are the clinical clues to the stages of syphilis? Just remember, in essence, there's infectious syphilis, as what I've mentioned, is primary, secondary, and early latent. Primary, of course, is manifested with a chancre, and that's the way the word's pronounced, chancre, not canker. And just remember that they're not always painless, and you sometimes have to look in non-genital regions, including the head and neck, for those. Secondary syphilis can really be easy to spot when you start to recognize the pleomorphic rashes that it produces, and oftentimes alopecia that's been unrecognized. And one of the real important clues is if you have an RPR titer that comes back on somebody you tested for syphilis, and it's greater or equal to 1 in 32, that's by definition secondary syphilis, because that's the stage of syphilis where you have the highest bacterial load. Early latent is a challenge. It's usually asymptomatic and is basically defined as less than a year since the initial infection. The non-infectious syphilis, which is what for most of my career I was referred patients, is late latent or tertiary syphilis, and those still pop up. But right now our main worry is the infectious forms of syphilis, both primary and secondary, and of course the consequences of congenital syphilis that are out there. And I think next slide, but I think that's it for me. So just keep your eyes open for syphilis.
Thanks very much, Gerald, and I'll just turn it over to Mahali for these next couple of slides.
Thanks, Eleanor. Just a reminder, the OCFP had developed a 2-page measles resource, and it sort of includes everything you need to know, including who might need an additional vaccine dose. And it also links to the public health guidance. So I'd encourage you to have a look at that. Next slide. And also just a reminder that we have a sick note template that you can use when employers have requested sick notes. And it sort of encourages employers to rethink their policies and helps to educate them. And that tool is now integrated for several different EMRs that you can see on the screen there.
Thanks, Mahile. And maybe can we take the slides down and we'll break for some Q&A for Gerald. Thanks very much for bringing us up to date on COVID. It sounds like generally good news in terms of numbers and also for informing us about syphilis. Couple of questions that have come in, and actually I think there might have been some issues with the upvoting on the chat. I don't know if people were experiencing that, but if you didn't have the opportunity to upvote, please do so that I can prioritize those questions. But our first question from Allison, the public health recommendations identify that we should boost over 65. It does not emphasize those at higher risk. Should we be boosting our healthy, I think, over 65s, or should we be waiting until the fall?
Yeah, that's a great question. And I'll just answer it very quickly. Age is the most important determinant of the severity and poor outcomes associated with COVID-19. So even healthy individuals over the age of 65 should be vaccinated because we know it has a dramatic impact on reducing hospitalizations, death, and complications, including, although it's less common than it used to be, long COVID. So yes, healthy 65-year-olds and over should still get vaccinated. I think that's a very, very smart strategy because we know that age is so important in the severity of outcomes from COVID.
Thanks, Gerald. Another question, Dr. Evans, can you please explain why when influenza A increases, it decreases COVID?
Oh yeah, except I'm not going to nerd out too much here. So there is a thing called viral interference. Viruses, when they infect a cell, tend to induce intracellular mechanisms that then prevent other viruses from kind of establishing an infection. We see co-infections, two viruses at the same time, but it's actually relatively uncommon other than in children. So what we're seeing, I think, in the last 2 years is the fact that when influenza gets up there and you get a lot of people with influenza, it actually prevents COVID from causing an infection in those individuals. When they're not infected with COVID, it's going to reduce overall numbers and reduce transmission in general. And that viral interference signal may be augmented again this year, as I said, by OC43, which is a human coronavirus that's been circulating in high levels.
Great, thanks, Gerald. Another question around COVID. What do you think about applying the precautionary principle to COVID-19, meaning prevent infection, reinfection as much as possible? Because we don't know about the long-term effects 10 to 20 years from now, and we know about long COVID currently.
Yeah, I will say it's very controversial. In social media, there's a lot of discussion about the fact that repeated infections increases the risk to have long-term consequences of COVID. We don't actually know that in the vast majority of individuals. It's speculative. It's based a lot on some anecdotal cases. So, you know, I wish I was clairvoyant. I could tell you where we're going to be 20 years from now. The precautionary principle is important, but again, we're not in the pandemic phase anymore of the pandemic. We're in a transitional phase. And right now, if you actually get sick right now, here where I am in southeastern Ontario, you're most likely either got influenza, either A or B, right now primarily B. You've either got OC43 or you've got a parainfluenza virus infection. COVID's actually like way off third. So it's really important to understand that in a way, we are looking at the dynamics of viruses as ones emerging, like SARS-CoV-2, along with the competition it's facing from all of the other pre-existing viruses. And before the pandemic came along, you know, I mean, most of us were worried about seasonal flu most of the time. The other viruses tend to produce a mild illness. So I think you have to put it kind of into perspective. And you know, how long do you stay in this sort of period where you try and prevent every COVID infection that's out there? The vast majority of people who have hybrid immunity and get COVID now get a very mild illness. So yeah, it's a difficult balance question, but my view is that, you know, we still need to be thoughtful and careful. I think vaccination is probably our most important strategy. And when we see higher levels in the community, maybe we're going to consider, again, reintroducing masking in many different many different places. But, we never did that for seasonal flu. And seasonal flu, by the way, is still a nasty illness. For those of you who have either had it or had many patients who presented with it, it's no walk in the park either.
Thanks very much, Cheryl. I'm going to just switch a little bit to, if you're okay with it, to MMR,
Sure.
because that's come up too. So a question, my pregnant patient asked if her partner gets MMR, a live vaccine. Is she at any risk of contracting anything from him being vaccinated?
So first of all, you have to think about the pregnant patient. If they're vaccinated, fully vaccinated with at least 2 MMRs in the past, you have nothing to worry about. Yes, MMR is a live virus vaccine, and people who receive it may shed small amounts of actual virus. It's an attenuated viral strain. But again, if the pregnant individual has been fully vaccinated against measles, mumps, and rubella, then it's irrespective of their partner getting their MMR vaccine because you've been protected by your previous vaccination. So the question might come up, is the pregnant patient not vaccinated? In which case, you got a challenge because we don't give live virus vaccines to pregnant people. That's a real challenge, all right. That's sort of one of the key things are off. So that becomes a little bit more of an issue. But I'm assuming since we're over 90% of the population vaccinated in that sort of age group that would be now pregnant, I think it's kind of more related to the status of the pregnant patient, not the person who got the vaccine who's a partner.
Great, thanks very much for clarifying that. Turning back to COVID, just a question. I've never got COVID-19 despite treating many patients with it and having household family members with it. Should I continue to get vaccinated regularly?
Right now, yes, we're still looking at those recommendations. And right now, it's probably emerging into semi-annual vaccination, so 2 vaccines a year if you're of a certain age or risk group, and make a seasonal vaccine or a once-a-year annual vaccine for everybody else. The interesting thing is that there are a small cadre of individuals who get COVID who never get symptoms. And therefore never have, tested themselves or whatever. And the way we detect those people, of course, is through serological assessment. Now, we don't do that as a clinical tool, but groups that I have here in Kingston, as well as other groups across the country, have been looking at sero surveys and showing very, very high rates. So it's quite possible that person might have had COVID and just didn't know that they did. But if you didn't have COVID, yeah, you should still get a vaccination annually if you're at sort of standard risk. And we're now probably going to get into recommending twice a year if you're at high risk.
Great, that's helpful to clarify where things stand for people that have managed to never get it. In terms of flipping back actually to MMR, parents of a 10-month-old asked if it's best to avoid contact with a 1-year-old friend for the first 2 weeks after the friend's MMR, just in case the friend is one of those who gets a weak measles infection.
Yes, so the vaccine contains an attenuated virus. So there is not a lot of evidence that recipients of MMR vaccine are likely to be highly infectious with even that attenuated strain. So we're back to the sort of pregnant patient question again, worrying about sort of the transmission of a live virus. We do vaccinate it a year and not usually before that, unless, of course, you're planning to travel. And right now there's a recommendation to vaccinate children under 1 year, and then, of course, repeat the vaccine at after 1 year. So I would not consider that a significantly high risk issue. If you wanted to keep them apart, that's fine. Although, frankly, the big problem you might have is they might be children in the same household, in which case, how the heck do you manage that? And that's a little bit more of a challenge, I think.
Absolutely. Just actually getting back to the question regarding the pregnant patient, because there's been a follow-up question. So Dr. Evans, the pregnant patient is non-immune to measles. Should the partner get vaccinated?
Oh, wow. Yeah. Gee. I love that. It's always these nuances. IND doctors face this. Yes, but what if? And that's the challenge. Again, I would sort of reiterate the issue that transmission of the attenuated virus strain from a vaccinated individual is low. And I assume that the pregnant patient, here's an example. I'm now getting into one specific patient where the pregnant patient maybe has a negative serological assay for measles of their measles IgG is negative. We don't know that necessarily doesn't mean that they're immune, although that is the kind of surrogate marker we currently use. You certainly could get the partner vaccinated But if you want 100% reduction in the likelihood of any kind of transmission of an attenuated virus to a pregnant woman, then you would keep them apart for, a couple of weeks or something to sort of wait for that. So a bit of an odd situation, but yeah, probably not as rare as we think, I think.
Thanks very much. Yes, there's always so much nuance. So actually, I think we're going to take a break now just so we can turn over to our next speaker. But there are still some questions in the Q&A. So hoping, Gerald, that you can have a look at some of them while Dr. Feldman's speaking, and then we'll come back to you at the end of that time.
Sure.
Okay, so maybe I could bring up the slide. If you could bring up the slides again, and I will now turn things over to Dr. Feldman to talk about osteoporosis.
Thank you so much, Eleanor. Thanks very much for the invitation to be here today. I know we only have a few minutes to go through a complicated topic, so I'll start by saying that the OCFP, with my colleagues Lynn Nash and Upi Mehan, are developing a 3-hour workshop on this, so I invite you to think about joining us for that in the future. Next slide, please. So these were the guidelines that we published in October of 2023. Next slide. And it's a group of family physicians, patient partners, experts in osteoporosis, exercise, and nutrition, pharmacists, and we had a grade methodologist from McMaster University helping to guide the process. And we made sure that we had at least one family doctor and one patient partner on every working group and in the steering committee. And then we also had a group of family docs who separately met to decide that we were in consensus around what the recommendations would be. We had a separate conflict of interest management committee, working groups in fracture risk assessment, nutrition, exercise, pharmacotherapy. We had unrestricted funding from Osteoporosis Canada, which paid for the methodologist and the librarians. Otherwise, it was all done on a voluntary, unpaid participation. Next, please. So the focus is to help us, family docs, community primary healthcare professionals, in screening postmenopausal females and males, age 50 and older, for the presence of risk factors for osteoporosis and fractures, hopefully to provide some interventions that would help to optimize skeletal health and prevent future fractures. And the focus is really on primary osteoporosis, not secondary osteoporosis, which we felt was sort of beyond the scope. Next, please. We use the grade process. I think it's really important to understand this, that recommendations are either strong, where we'll say we recommend, or conditional, where we would say we suggest. And for the recommend, there's strong evidence or strong support for most individuals would want this recommendation. The suggest are somewhat weaker, either based on less convincing evidence or that we think that individual patients need to make really careful decisions about their own values and preferences. And in particular, we were guided by a survey of about 1,000 patients that with osteoporosis who helped to inform the recommendations by saying that prevention of fractures was really critical to them as a group. Next slide, please. So I always say that I'm not now, nor do I ever want to be an osteoporosis expert. There are too many things in family medicine that are interesting. But the reason it's important to me is I guess over the course of my career, I've seen so many people who've had profound impacts from fractures with real disability and people who've died afterwards. So it affects men and women. 1 in 5 Canadians with a hip fracture died following. And it's something that affects both men and women, with interestingly, men 1.6 times more likely to die of any cause within a year of fractures. So just to highlight that the importance to us from a public health perspective. Next slide, please. So this is one of my favorite slides to look at. This is my wonderful wife, Karen, with our son, Benjamin, who's now 26. And aside from the fact that I love to look at both of them, next slide, please. It reminds me to remind you that we have a remarkable opportunity as family docs to not just recognize and treat osteoporosis, but to build bone in the first place. So thinking about our really younger patients, helping them to have healthy diets, to exercise well, to try and avoid alcohol and nicotine, the kind of things that can make their bones weaker when they get older. So really critical to remember that the prevention of osteoporosis actually starts very, very early on, and that we have a real opportunity to make a difference here. Next slide, please. Let me take you through a little bit of the two parts of the algorithm for first risk assessment and then treatment. Next, please. So the first step is to use clinical risk factors to identify who might be at higher risk for fracture. So the whole point is to try not to treat the folks who are at low risk and to really emphasize treatment for people who are at higher risk. Identifying previous fragility fractures is really critical. So people who have broken a bone when they shouldn't have broken a bone, a walking pace or less, standing height or less, and they break is probably not something that our bones should do. So really, really important to identify that. People who are on glucocorticoids, and you'll see that the dose of prednisone has decreased from the 2010 guidelines from 7.5 milligrams down to more than 5 milligrams daily for 3 months. The presence of falls is new. Falls is not in the FRAX algorithm, and it's such a critical part of fracture that we thought it was really important to highlight that as a risk factor. There is a genetic component, so if a parent fractured a hip, being on the thin side makes you much more likely to fracture, or the risks from smoking and alcohol to your bones. And there's a long list of secondary causes of osteoporosis. There's a nice table in one of the appendices of the guidelines that lists all of them, but there are many to highlight as well. Next slide, please. One of the newer things that we know is that having a fracture puts you at significantly higher risk for another fracture in the few years following. So analogous perhaps to the idea that after a stroke, the incidence of a second stroke is highest immediately following. The same thing is true for fractures. So if you look at, for example, the third set of columns for hip fracture, if you fracture your hip at the 2-year mark, there's a 15% chance that you're going to fracture another bone, or at the 5-year mark, a 25% chance. So really important when people have broken a bone that we use that as an opportunity to really think about whether they should be on fracture prevention medication. Next, please. The next thing we do is we look for the clinical signs of vertebral fracture. Next. So this is a picture of me and my dad. I think there are a few things that are clear in this. He's an 87-year-old retired ophthalmologist. First of all, I think my paternity could never be questioned. Second, I think we have excellent taste in shirts, although I have pocket envy. And the third is that my dad used to be 6'3" and I'm just shy of 6 feet. So he's lost a good 3 inches since he was a young man. Next slide, please. And the presence of height loss should be a clinical twig that we should do an x-ray to see if there are vertebral fractures. Now, there may not be. People lose height for many reasons, but there may be asymptomatic vertebral fractures that we want to pick up. And the magic number is 2 centimeters of measured height loss or historical height loss of more than 6 centimeters. So say 2.5, 3 inches of height loss. Those would be the twigs that you want to be doing an x-ray to see if there are vertebral fractures. Next, please. After that, what are we going to do with that information? Well, if you're less than 70 years old and have no risk factors, don't do anything. If you're in those middle categories, if you have a previous fracture or 2 or more risk factors from age 50 to 64, if you're age 65 to 69 with one of the risk factors, or you're age 70 with no risk factors, then we recommend going on and doing a bone density and calculating a FRAX. And the reason is that from the Manitoba database, the registry, this is approximately a 10% FRAX risk for any of these different categories. So that was the threshold where we thought it was worth at least looking a little bit further by doing a bone density and then calculating a more accurate risk of fracture. And then again, there's a gradient from very little risk to very high risk. For those who are at low risk or less than 15% chance of fracture, we don't recommend any kind of therapy. For people who are in the 15 to 19.9% risk, there's a suggest. Remember, on grade, that means have a really careful conversation with your patient about benefits and risks. And then for those who have a 20% or more fracture risk, or really importantly, if they've had previous fractures of the hip, of the spine, or more than 2 other kind of fractures, then we would actually recommend therapy. That's where the highest benefit is. Next slide, please. Unfortunately, there is a real discordance between the Canadian Task Force on Preventive Health Care and the Osteoporosis Canada recommendations. I don't really have time to go into the differences very much. I think there are benefits to both approaches. So the Canadian Task Force suggests screening all females 65 and older. They suggest doing a FRAX without a BMD, remembering that falls are not included in the FRAX. Then a BMD if people are interested in treatment, and then a second FRAX with a BMD at that point, and then using that to base the results, using that result to base treatment recommendations. Very specifically recommend no screening for males. Our recommendations, as I've said, females and males over the age of 50, again, using the clinical risk factors, just like would be in FRAX, but with the addition of falls. The BMD based on that risk, again, that 10% sort of threshold approximately, doing just a single FRAX then with the bone density, and then recommendations for screening and treatment for males with a lower grade level, and providing exercise, nutrition, and pharmacotherapy recommendations. So the most important thing is that you do something, because I think this is a situation where doing nothing is probably the wrong approach. Please look at both, see what makes sense to you, what's concordant with your approach in other ways, and just pick one that makes sense to you. Next, please. So let's move on then to management. We don't recommend any additional supplementation to prevent fractures with calcium or vitamin D. They don't seem to add any benefit for fracture prevention, but for general good bone health, there's a recommendation around a reasonable amount of calcium through the diet. Osteoporosis Canada has a nice calcium calculator for our patients if it would be helpful. And then for vitamin D, to use the RDAs from Health Canada as well. My patients who are already taking 1,000 units, I don't say to change that. I just say leave it alone. But for those who are not taking anything, the recommendation is the 600 units for lower age, and then the 800 units a day for over age 70. Next, please. Exercise. So the exercise literature really focuses much more on falls than on fractures. And so we recommend balance and functional training at least twice a week to reduce the risk of falls. And we suggest progressive resistance training, really important that word progressive, so that exercise has to be hard and it has to get harder. And even for older people, that's true. Walking is amazing, but unfortunately, it doesn't reduce the risk of falls. So for our patients who are just walking, it's great, but they need to do something more in terms of balance, functional training, resistance training to protect them from falling. Next, please. So in the slides that you'll get, I've put some of the resources that might be helpful to help find the kind of exercise which is safe and beneficial for older people. Next, please. Next, please. So in terms of pharmacotherapy, some changes here as well. For people who have a recent severe vertebral fracture, so a fracture in the last 2 years with a loss of at least 40% of the vertebral height, and you can go back to the radiologist and ask them to clarify if they just say there's a fracture. And they have a low T-score, so really not dense bones. Recommendation is for first-line anabolic therapy. That's bone builders with teriparatide or romosozumab. Next, please. For most people, though, we're recommending a bisphosphonate first line for a short duration of time, from 3 to 6 years. The longer duration is if they have a history of hip fracture, a vertebral fracture, or multiple non-vertebral fractures, or ongoing risk factors like being on medication that might be weakening their bones. We stop after 3 to 6 years. We take a break, a drug holiday for 3 years, and then we reassess to see if they're still in need of further treatment. Next, please. If people can't tolerate bisphosphonates, if they can't swallow well, if they're getting GI upset, for example, then denosumab is the next alternative. This has to be long-term uninterrupted therapy, so there's no drug holiday with denosumab. And when you stop, you have to transition to another agent like a bisphosphonate or some other alternative, because otherwise there's a flare in vertebral fractures. So really important not to stop it abruptly. Next slide, please. Why? So the reason is that the risks of bisphosphonates continue to increase over time. but the benefit seems to plateau at around the 3 to 6 year mark. So this seems to be around the right window to say, yes, the benefits far outweigh the risks. As time goes on, though, the longer you're on the drugs, the more the risks increase, the benefits do not. So that's why we have this concept of a drug holiday for bisphosphonates. Next slide, please. With denosumab, though, that does not seem to be true, that the risks of AFF and ONG are relatively stable over a 10-year period, and the anti-fracture benefits don't wane either. The reason that we don't go beyond 10 years is simply that we don't have any studies. So it may be that it's fine to stay on a denosumab for 15 years or 20 years. We simply don't know yet. And again, just to reinforce the importance of no drug holidays and and a need to transition to something else afterwards if you're going to stop it and move on to something else. Next slide, please. And then finally, when do we reassess people? So if you started pharmacotherapy, then it would be at the 3-year mark. But if you're not choosing to start pharmacotherapy, if your patient decides not to take anything, if they are low risk, 5 to 10 years, in my opinion, 8 to 10 years is perfectly fine. If they're at a bit of a higher risk of 10 to 15%, probably a 5-year repeat is reasonable. And then if they're at a higher risk, more than 15%, probably at the 3-year mark. And the reason that it's not valuable to do it more often is that there's a lot of variability in the test itself, and that a shorter interval really doesn't help you to have more accurate information. It just might give you more noise. And with that, I'll stop and happy to answer any questions that have come up. Thank you. So in summary, falls are bad, fractures are really bad. Please try and build bone early. There are similarities and differences between the task force and the OC guidelines. Read them both, see which one is concordant with what you believe, and then use one of them. The important thing is for people who are at low risk, really focus on fall prevention, strength and balance, avoiding things like alcohol and smoking. Treat people who are at high risk, particularly people who have recently had a hip or a spine fracture. You can take a break from bisphosphonates. Sorry, I couldn't resist. And then for denosumab, no break, don't stop, transition, or with an increased risk of vertebral fractures if you don't. And then for males, there's weaker evidence, but in my opinion, no evidence. And different guidelines around the world certainly have made different recommendations. Certainly most would recommend treatment of males. They have worse fracture outcomes, but important to have those conversations directly with our male patients. And I'll stop at that point. Thank you.
Great. Thanks so much, Dr. Feldman, for bringing us up to date on the latest guidelines and answering, I think, actually quite a few of the questions that were in the Q&A, but we'll go through them and just make sure that we cover the ones that are really keen to be answered. Perhaps we can take the slides down. Perfect. Thanks. So first question, can we do bone mineral density during menopause as a baseline? A lot of my patients at that point have, quotes, low bone mass, but low fracture risk. What do you do with that?
Yeah, I think there's not much value in doing those early bone densities for people without the risk factors. So really using clinical risk factors to guide our approach, I think is a more prudent approach. So doing that either by identifying those clinical risk factors in the list, particularly if they're folks who fall, or do a FRAX, and then if the FRAX is high, then you can go on and consider bone density if the FRAX without bone density shows that they're at risk. But for routine screening, there's no value.
Great, thanks very much. So another question, should patients on bisphosphonate be put on a drug holiday before going for dental workup, or should dentists be making that decision or recommendation?
Yeah, that's a really tricky one. And if you go to the OC Canada website, there's actually nice guidelines on this. Remember that there's prolonged residence of bisphosphonates in the bone. So if you stop it for a month or two, it's still going to be there. So there probably is no great value in stopping the bisphosphonate beforehand. What I do recommend before starting therapy is that people see their dentist and make sure everything's okay before we start to initiate treatment. Remember as well that the time to benefit from treatment is probably 9 to 15 months. So there is a window of time in that early period where it's still very reasonable to be doing dental work. but I don't think there's much value in stopping the medication in order to have dental.
Great, that clarifies things for the dental perspective. Another question regarding bone density, and I think many of us experience this. Every X-ray report I see from my radiology department says osteopenia suggests BMD to rule out osteoporosis. Should I then be ordering the bone density?
Yeah, I don't know. It's a real challenge, that one. I suppose if somebody has other risk factors for osteoporosis, that would be a reasonable thing to do. If there's a chest X-ray and there are vertebral fractures, different story. Otherwise, I'm not convinced that that radiologic suggestion of osteopenia really makes sense in terms of getting a bone density done personally. I mention it to my patients, and if they're interested, then I might consider doing that, but not otherwise.
Great,
Because
thanks.
again, like everything else that we do, right? It's what are we going to do with that information? Right. So we're going to do a bone density in order to find out that they're low risk, probably, right? It would be pretty unusual for us to see that they're going to be at high risk and in need of treatment.
Excellent, thanks very much. A question regarding, and I think you did in fact answer this during the session, can osteoporosis treatment go directly to denosumab or always start with bisphosphonates? But perhaps it would be helpful to just review.
Yeah, no, I'm happy to. Yeah, so the recommendation is to start with a bisphosphonate for most people, for those who are at highest risk. So remember, the people who've had the severe vertebral fracture and a low bone density, there's a recommendation for one of the bone building anabolic agents. For everybody else, it's a bisphosphonate, except there are some people who can't tolerate bisphosphonates, and that might be difficulty swallowing. Maybe they can't sit up for a long period of time. They get a lot of GI discomfort with it. So those might be some typical examples of times where we would start with denosumab instead. If somebody has fractured while they're on a bisphosphonate, then one could continue with a bisphosphonate because, of course, there's no medication that's 100% effective. We don't expect 100% efficacy from a bisphosphonate. So you could continue with the bisphosphonate, or at that point, you could consider switching over to denosumab as another alternative.
Great. In terms of another question regarding the medication, so drug holidays after 3 to 6 years, is this regardless of the results from the BMD study? What if the T-scores are unchanged after 3 to 6 years of treatment with bisphosphonates?
Yeah, so that's a great question. There will be probably a subset of people who you might consider continuing on. For example, if they have had a fracture while they're on treatment. But remember that there is that prolonged residence in the bones. You still have the drug in the system for another 2 or 3 years afterwards. So it might still be reasonable to stop the medication and then restart it 3 years later. And you can have no change in bone density, but still that may still be helping to maintain bone strength. So it may still have been beneficial without necessarily an improvement in bone density. I would say that there are some of our osteoporosis expert colleagues that are starting to talk about treating to a target bone density in the same way that there are people who talk about treating to a target LDL level. But like with LDLs, most of us, I think, would say that the approach one should take for the majority of people would be to take a pause and then to restart.
And actually, along that idea of taking a pause and restarting, there's a question here: what criteria defines a reason to restart bisphosphonates after a 3-year holiday, considering variability?
Yeah, that's a really great question. So it's like you're starting de novo. You're starting from scratch. So 3 years later, you're doing another clinical assessment. You're doing another bone density. You're finding out where somebody falls in terms of their risk level, and then making a decision at that point about whether, if this was a new start, what would you do, is sort of the way that I think of it.
Excellent. So just in terms of treatment, other than medication, someone's asking about, can you talk about magnesium, vitamin K2, and protein for prevention of osteoporosis?
Yeah, for sure. And if you look at the guidelines, it was just because I felt limited in our time today. There's a much more extensive discussion around diet. So the group that looked at diet did look specifically at magnesium. They did look at potassium. They looked at protein. The magnesium data, I gather, was not particularly convincing, so there's no recommendation to supplement with any other kind of mineral other than with calcium and vitamin D. Protein, we want to be in the 0 for older people, anywhere above 0.8 grams per kilogram of protein per day, probably getting up towards 1, maybe up to 1.2, but no added benefit beyond that. So hyper supplementation was not shown to be helpful.
Excellent, and good to know. We can check the guidelines for more details because I know we were very specific about how long we wanted you to chat for. Wanted to ask you a few questions again that are coming up, and I think this is something we all face in the office is regarding differences. For example, should GPs be ignoring the CARIC-based text suggestions reported by radiologists? I know there's a couple more parts to this question. Had one patient with a radiologist stating low bone mass and low risk, but FRAX giving moderate risk. Is it normal to have discordance between the CARIC and the FRAX? And along the same lines, why do radiologists' recommendations frequently not agree with FRAX recommendations regarding follow-up interval?
Yeah, the latter part of the question is probably complicated, and I don't want to accuse anybody of doing anything for financial gain. So that, I'm sure that radiologists are not recommending repeat scans more frequently because there's a benefit to them for that. I would imagine it's because they feel that there is the potential for loss over a short interval of time. The interval, though, really, there's very little evidence that for people who are at low or usual risk, that more frequent testing of bone density is particularly helpful. For people with secondary osteoporosis, it might be a different story because they can lose bone much more rapidly. There's a real challenge with the CAROC recommendations, which was originally the Canadian Association of Radiology and Osteoporosis Canada. That's the OC part. And really what they've done is CAROC extracts from FRAX the most important risk factors like age, bone density, and the presence of a previous fracture. Bill Leslie in Manitoba did a really nice study comparing CAROC and FRAX and found that FRAX, in every case of discordance, FRAX was more likely to be accurate. It's not a huge difference. It was in this, less than 10% range. Less than 5%, I think, most of the time. So if all that you have available is the CAROC, then it's not unreasonable to use that. The challenge of CAROC is that it divides into the 10% or less, 10 to 20%, 20% or more, and our guidelines really talk about 15% as a threshold. So what we're hoping to do is to work with the Ontario Association of Radiologists to see if we can come up with an agreement that we'll switch from CAROC to FRAX reporting by our radiologist so that we no longer have this discordance, which is creating such a muddle for those of us who are in practice. What I would do in that situation is probably to ignore it, calculate your own FRAX, and use that as the basis for moving forward.
Great, that's helpful in terms of understanding why there's some differences there. And I'm going to ask you one quick question before I turn things back to ask some questions of Dr. Evans. But just in terms of using the FRAX tool, Kathy comments that she never knows what type of BMD X-ray machine was used because the report doesn't clearly identify it. Which machine type should be clicked on the online FRAX tool?
I always click on just where it says the T-score because I don't know either. So if you can just click on T-score and enter minus 2.8 or whatever it might be without knowing the specific machine.
Okay, excellent. Thanks very much. So I'm just going to turn over and ask a few questions of Dr. Evans. And I know he's actually answered a lot of them by typing out his answers, but I wanted to bring him back on. So just one question was around the use of Paxlovid, and feel free to, if you've written the answer, just to read it out. The use of Paxlovid, now that cases are often mild, is there any new data about it and how efficacious is it?
Yeah, so some people may have already heard in the New England Journal of medicine this week. The EPIC SR study was finally published. So SR means standard risk. So it was looking at the use of Paxlovid in people who are standard risk, not high risk. It basically showed that there was no advantage to the use of Paxlovid in those individuals. Duration of symptoms was exactly the same length. There was a tendency towards less hospitalization, but it was not statistically significant. So when I talk to most of my colleagues in primary care, you guys have been amazing because I've not seen a lot of overuse of Paxlovid in low-risk individuals, which is what EPIC SR told us. And really right now it should be confined to people who are at higher risk. And again, our recommendation, it came out through the Infectious Diseases Advisory Committee of Ontario Health, was to actually reserve it for those individuals. Obviously, people who aren't vaccinated and elderly definitely should get Paxlovid because we know that those are the ones that are at the highest risk. But if you haven't seen it, you can probably get it. I'm sorry, I'm an academic, so I can always get all these journal articles for free. But yeah, that's basically what the EPIC SR study showed. So I think the use of Paxlovid in younger people at low or what we call standard risk is really not useful at this point.
Thanks very much. Another question, quick one regarding what's OC43?
Oh yeah, it's a human coronavirus. It's been circulating around the human population probably for about 500 or 600 years. It causes a common cold-like syndrome. Some people would suggest that it's the one that you get where you get a little bit of a GI symptoms with it, or maybe a slightly worse cold than you'd get with a rhinovirus. But yeah, it's been around for a long time. Almost all of us have had it. Yeah, just the standard human coronavirus.
All right, great. Thanks for clarifying that. There was also a question around how do you test for an chancre? I've forgotten that. You told us
Yeah, that was a good question. I answered that one. So
Okay.
the old-fashioned way was to take some material from the chancre without blood in it and look at it under a microscope. But you have to use a very different technique. And nowadays, I'm trying to remember what we called it back in the day. It's so old. Nowadays, you can use a phase contrast microscope. Most of you don't have microscopes that do phase contrast or dark field. That's what it's called, dark field microscopy. So if you want to sample a chancre, you can't do it in your office. You need to send them to a sexual health clinic or to a microbiologist. One of the little treats I can give you, though, is if you talk to the lab and send a blood sample, in early syphilis, before the RPR, aka the VDRL, becomes positive, the specific treponemal test, in particular, one of them called an FTA-ABS, which is a fluorescent treponemal antibody absorption test, becomes positive earlier than all of those other tests. But you have to talk to the lab because they have that algorithm I showed you, the sort of way they sequence things. But if you explain to them that you got a patient with a chancre very early, you're unable to get the chancre tested using microscopy, could they do an FTA-ABS if you submit a serum sample? That might be your clue. And if it's positive, yeah, you got a case of very early syphilis.
Excellent. So another question, actually flipping back to measles, mumps, and rubella, which is still on everybody's mind, obviously. Can patients on methotrexate for psoriasis get the MMR vaccine?
Quick answer, no. Live virus vaccines are contraindicated in people who are on immunosuppressive therapies. The only, I'll go to the rheumatological group because that's the question all my rheumatology colleagues send me. The only ones you can probably give MMR vaccine to is if you're under controlled with just hydroxychloroquine. If you're on steroids, if you're on methotrexate, or you're on any biologics, absolutely not. You cannot give a live virus vaccine.
Excellent. There was another question actually regarding MMR vaccines in patients who are on pharmacologic and immunosuppressants. And I'm just going to read it through to you. I think you've just answered it now in terms of your response, but let's just check. I know that MMR can be considered upon consultation with someone who has expertise in ID about this, but given the increase in cases, sometimes it's just not practical for us in primary care to consult ID. I sometimes use the resource below, which is a MedSask resource, but I'm wondering if public health has practical tips to address this. For example, patient using methotrexate and hydroxychloroquine for RA, should we be consulting rheumatology to advise on vaccine safety, or is it imperative that we consult ID?
If you talk to the rheumatologist, they'll call me. or one of my colleagues. So it's a chain reaction effect. Yeah. So again, the general consensus, the general recommendation is you do not give live virus vaccines to people who are immunocompromised, either due to their underlying illness, in which case you might want to talk to an ID doc. If they're on any kind of therapy other than the mildest of immunosuppression, I just gave the example of hydroxychloroquine alone, you basically should not give an MMR vaccine to.
Okay, thanks for clarifying that. I was just going to go to a question that you did answer in the chat. So, Dr. Evans, if a doctor had a booster MMR 20 years ago in med school, should we get a booster again? They were born in the cohort 1970 to 1991, and I just wanted you to reiterate that answer for those people that might be listening, not watching.
Yeah, if you've had 2 doses of MMR, particularly one when you were an adult, which is what this person who asked the question was all about, you do not need anything more. You are well protected. The challenge becomes ones of, are you now old enough that you've some other issues of you're suffering from an immunocompromising condition, and maybe there has been some waning. There's 2 really important things. If you had measles, you don't need any more vaccine. Measles infection by itself is very substantial, has a very long duration, and confers great protection. And if you've had at least 2 measles shots that you know of, particularly one when you were either an adolescent or an adult, you really don't need anything more. And I would not be, like, for instance, even testing you. We've got to kind of tone down some of the over concerns that are going on. 2 shots of the MMR at age 1 and then some point further on confers what we think is pretty substantial protection.
Right. Well, that's reassuring to hear. I'm actually just going to bring up the slides again, and we'll just go through our last few slides, and then we do have still quite a few questions. So if there are people that want to stay on, we'll go through some more of the questions, but we'll just finish up with the main presentation. So just wanted to bring people's attention to this Green Office Toolkit. Again, thinking about Earth Day this month, which just was revised in 2023. It comes from the Canadian Coalition for Green Healthcare and has lots of great suggestions on what you can do to green your care. Next slide, and over to Mehele. Oh no, also a reminder about the Can Treat COVID program research trial to please register your patients if you have any that would be eligible. And now over to Mehele.
Thanks, Eleanor. Just a reminder, some of the OCFP supports for mental health addictions and chronic pain. We have our community of practice sessions, and the dates between April and June are outlined there. And we also have our Peer Connect mentorship group, and the deadline to register for that is April 12th.
Just a reminder, you can check out all our sessions online, as well as the resources that are posted with them. Next slide, please. And that they are Maine Pro accredited. Next slide, please. And if you have any questions, and our next community practice will be April 26th. Next slide. I think that's it. Yeah, so maybe take down the slides, and then for those of us that can stay on and would like to listen to some of the answers to the other questions, then I think we'll actually head back to Dr. Feldman, because I see a lot more coming in regarding osteoporosis. So can we give oral calcium supplements to patients with significant vascular calcifications?
To my knowledge, yes. I don't think, I mean, the homeostasis of calcium is pretty tightly regulated in the body. So I would imagine that calcium supplements could be used, remembering though that the real emphasis is on dietary sources. And we recommend no more than 500 milligrams of additional calcium from a non-dietary source.
Great. Another question regarding vitamin D. Most patients need 3,000 units of vitamin D to get their blood levels to more than 100. Is 600 to 1,000 really enough?
Yep. Yeah, you don't need to have serum levels that high in most countries. The target is actually a serum level of greater than 50, and probably fracture risk is prevented even above 40. So the harms probably outweigh the benefits from that kind of mega supplementation with no benefit for fracture prevention.
Great. Another question just regarding treatment. So Prolia, can it ever be stopped? And can you describe a few situations in which stopping it will be appropriate?
Yeah, so I suppose the risk of atypical femoral fracture is not zero with denosumab. The risk of osteonecrosis of the jaw is not zero. So if somebody were to develop those complications, that would probably be an appropriate situation. If somebody has sustained multiple fractures despite being on denosumab, then there might be consideration for switching over to an anabolic agent. I would certainly not be doing that myself. I would be consulting an osteoporosis specialist to help to guide that.
Okay, thanks very much for that,
Yeah.
Sid. Another, just flagging some questions around bone testing, like serial bone testing after drug holidays. So from Vincent, in the past, we've been advised never stop the anti-osteoporotic medications for high-risk patients. The 2023 guideline seems to suggest that medications can be stopped even in high-risk patients if reevaluation of their condition shows they've moved from high risk to moderate risk category. Is my understanding correct, or am I overinterpreting the new guideline? And then if indeed we stop their medication, how soon should we repeat their bone mineral density? 1.5 years, 3 years?
Great question. Yes, your understanding is correct that even for the high-risk patients, the new recommendation would be to stop. That might be somebody, though, where you consider rather than waiting 3 years, perhaps 2 years to repeat their bone density to make sure there hasn't been a dramatic fall. Dramatic meaning a more than 5% loss of their bone density at that point.
Excellent. And then a question which I think you started to address, it's a tricky one, is why don't the committees coordinate? Why are there two different osteoporosis guidelines released in 2023, one that we're talking about and one by the Canadian Task Force?
What a lovely question. Yeah, we reached out to the Canadian Task Force. There was an opportunity for feedback on their guidelines from Osteoporosis Canada, so we did provide them with some information. But at the end of the day, I guess they're separate organizations that made their own separate recommendations. And I think, it's their threshold perhaps is slightly more stringent in terms of looking for RCT evidence as opposed to perhaps evidence which is from other sources. So it's a murky and muddy kind of literature. So on the one end, you have Therapeutics Initiative in BC, for example, just came out with a recommendation that FRAX doesn't work, treatment probably doesn't work very well, prevent people from falling. And then there's the Canadian Task Force recommendations somewhere in the middle. And then there's the Osteoporosis Canada guidelines that are a little bit more in terms of recommending in terms of treatment. And then there are many other guidelines in the world that are even more liberal in terms of recommending treatment. So it is a literature that seems to lead to multiple different interpretations. I'm really sad that there isn't more concordance. It would be really lovely to be able to say that we're saying the same thing, because it makes it challenging for us with our patients to decide what to do. I hope that doesn't lead to us throwing up our hands and saying, this is just too complicated. I'm going to ignore it. Because one way or another, we all want our patients not to fracture. We all want the same thing. And it's just a different interpretation of the literature using different thresholds, that's all.
Thanks very much, Sid. And I know, as all being family doctors, we appreciate the confusion that arises, but also that, the literature, there's lots of different research out there. Getting back to in terms of risk factors for osteoporosis, can you discuss why a BMI of less than 18 is a risk?
BMI less than 20?
Less than 18, actually.
No, it's less than 20 in the guideline.
Oh, okay. All right.
Yeah.
So maybe why less than 20 is a risk?
Yeah. It's interesting. I'm not sure exactly if that is as simple as less tush. So you fall, you have less padding, you're more likely to break. Or if there's something metabolically that happens, we know that people with eating disorders, for example, are much more high risk for osteoporosis. So in all likelihood, there is probably some hormonal influence on this as well. But it may be as simple as less padding when you fall. One of the reasons why older people have a lower mortality rate when their BMI is a little bit higher.
Okay, that's good to understand. In terms of older patients, so what about an 80-plus-year-old man with chronic kidney disease, mildly elevated creatinine, and a new diagnosis of severe osteoporosis, although no history of fractures? Is Prolia safe in chronic kidney disease?
Yeah, you have to be really careful about hypocalcemia. I'm comfortable using it with a creatinine clearance down to about 20, but my osteoporosis colleagues who are experts in this area will treat dialysis patients as well, but that's beyond certainly my scope. And I would make a referral for something like that to somebody with expertise, because renal osteodystrophy and renal complications are much more difficult to handle. But by the same token, these are folks who are at higher risk. Yeah. So in that case, I would be probably making a referral to somebody with more expertise, even if it's by e-consult.
Okay, that's helpful to know. In terms of somebody's asking, what's a treatment for compression fractures?
So in terms of the actual therapy, there's really, other than the consideration of trying to prevent another fracture, it's just pain management at this point. We used to use things like calcitonin, we used to use vertebroplasties and so on. My understanding is that the literature is fairly weak in terms of the benefit of those things, but I would have to defer to somebody with more expertise. So in my own practice, it's really a question of trying to prevent the next fracture and then managing pain, and then very careful mobilization and exercise.
Great. A question here, and I think probably just this is one of these take-home points. So Dr. Feldman, hello, your dad looks great. Great lecture in pearls. So bisphosphonate holiday after 5 years for how long? And Prolia forever, ? So I believe you answered this, but let's just make sure.
Yeah, I mean, that's so bisphosphonate holiday for 3 years and then reassess. Bisphosphonate for 10 years, possibly longer, we just don't know. So I'm hoping that as time goes on, some of these long-term trials, which are continuing, will have 15-year data, maybe 20-year data. But at this point, we don't know what the answer is to that.
Thanks very much. Just the question regarding Prolia, what's the downside of starting at first line?
Yeah, so there are risks that our pharmacotherapy group identified from the literature, including an increased risk of infections, of cellulitis, in particular, was one of the things that was flagged, and the idea that we have significant benefit from other medications that may have more studies behind them. So I think that was probably the recommendation in favor of that as first line. Also, a much more expensive drug. And so when you do the grade recommendations, that's one of the things that is factored in as well. So that was one of the other factors that was used to make a determination.
Okay, and I think we'll finish up with maybe 1 or 2 more questions. So for patients with bilateral hip replacements, what screen do you recommend? And would you start bisphosphonates based on other studies besides BMD?
Yeah, that's a really interesting question. So in that case, you would use probably the proxy of the spine. They'll do wrist as well sometimes, or forearm. In people like that, they'll do bone densities on the forearm as a proxy. If they fractured and that's why they ended up with arthroplasty, then that would probably put somebody at high enough risk that I would certainly be considering therapy. If it was just osteoarthritis leading to hip replacements, then they aren't necessarily at any higher risk for osteoporosis. So it would be the same process that we would use for anybody else, just using the spine and something like the forearm of the radius.
Great. Thank you very much, Dr. Feldman, for answering many of the questions. And thanks to Dr. Evans for answering questions, and for both of you for your talks, and for answering questions in the background. I was going to just finish by reading one that had come up regarding the measles vaccines. We see the guidelines regarding patients born before 1971. But practically speaking, are we giving the vaccine if the patient is concerned? I have a patient in their 80s and 90s who are concerned. Are they at high risk? And I was just going to read Dan's response here, which was, Patients born before 1970 in Canada are very likely to have had measles infections as children, to have lifelong immunity, even if they don't specifically remember having had an infection. If they've been born outside of Canada, even more likely to have an infection, and they're definitely not a high-risk group, and I'd reassure them of this. And if they remain significantly concerned, they could be eligible for a single dose of MMR if they have no documentation of having received one ever before, but unlikely to be of benefit. And unimmunized children are the highest risk group. Anything to add there, just from you, Gerald, in terms of dosing in older patients?
No, Dan aced it. Yeah, if you're 80 or 90 and you didn't get measles, you should be buying lottery tickets. Like, gadzooks. Yeah, no. And it is safe to give MMR even in very elderly people. Yeah, Dan got it perfect.
Excellent. Well, we'll finish with that for today. I hope everybody has a wonderful weekend. Be sure to check out our resources and review the slides and video if you didn't catch everything this morning or had to leave. And thanks again to our team and Dr. Feldman and Dr. Evans for speaking. Take care.